So, a very good evening to all the respected listeners. Myself, Dr. Ashima Farooq, MBBS MD Physiology. Today, we are going to discuss a very important cause of cardiovascular mortality in India, not only in India but all over the world. It is a case of cardiac failure, which normally result into the cardiac arrest and death of the many patient, and it lies under a very hidden iceberg. And we are just going to unveil all the things which are actually related to this cardiovascular mortality. So we'll just quickly come to the case-based scenario. I'll just tell you about the history of a patient. There is a 55 years old male who is presenting to OPD with complaints of shortness of breath. So what is shortness of breath? सांस लेने में दिक्कत. Okay, that is the primary chief complaint. Now, this breathlessness is associated with normal exertion. Okay, it's a normal exertion like walking or standing from a sitting posture and then just walking for 2 days, 2 minutes, and which a few years back he could do without any problem. Okay, the patient will not be having any problem in walking, going to the garden and walking for a while. But now the patient is suffering from breathlessness, and during sleep, he often gets an attack of severe shortness of breath and coughing, which awakes him from sleep. So, all of a sudden, he's sleeping, and again, there occurs a severe shortness of breath and coughing, and he awakes from sleep. So, the patient is also suffering from insomnia. Now, this episode of coughing persists even in the sitting position. Okay, it is not getting relieved by changing the posture of the patient. The episode of coughing is persisting even in the sitting position. This is what the patient is complaining. Okay, the shortness of breath is also termed as dyspnea. So it's either dyspnea at rest as well as dyspnea on exertion. And it seems that this patient is actually having a respiratory discomfort. But let's just quickly go to the general physical examination. The patient is calm. Okay, that's the mental state examination, that the patient is calm, he's conscious, it is well oriented to time, place, and person. Now, if we do to the palpation of the pulse, pulse comes out to be 90 per minute with characteristic pulsus alternans. Now, I would like to elaborate this. The pulse, normal pulse rate is 60 to 100 per minute, but we know this is going towards the higher side. Normally, it is on average 70 to 72 per minute, but this patient is showing say 90 per minute. So, a sort of tachycardia is there with characteristic pulsus alternans. What do you understand by pulsus alternans? Pulsus alternans means alternating strong and weak beats. Or in terms of amplitude and strength of pulse, they are alternating very strong and then it is followed by a weak pulse. So they're alternating strong and weak pulse, but the rhythm of this kind of a pulse is regular. Okay, on palpation, you will find that there is alternating strong and weak beats, but the rhythm of the pulse seems to be regular. That's what we call as pulsus alternans. And clinically, this condition is seen in case of severe left ventricular dysfunction. Okay, so primarily we were thinking that the patient might be having a respiratory problem, but on pulse examination, we came to the conclusion that it is of cardiac origin, as there is some sort of tachycardia and it is associated with alternate strong and weak pulses. So we could identify that this is a cardiovascular pathology. Now, what is the BP of the patient? It is 130 by 90 mmHg. Again, it is towards the higher side. Now, you can say that the sympathetic overdrive is there in the patient. The patient is not able to sleep properly. Okay, and the patient is also experiencing hypertension and tachycardia, a sort of, it's a subclinical condition. Now, pitting edema is seen on the ankles with +2 grade. What do you understand by pitting edema? First of all, let's see what is edema. Edema is the collection of the fluid in the interstitial spaces. So peripheral edema is commonly graded clinically based on the depth of the pit which is produced after applying pressure to a swollen area, usually over the shin or the ankle, and how long the pit distortion is persisting. Okay, so depending upon that pitting, we declassify edema into pitting and non-pitting edema. Non-pitting edema is seen in where a pit is not developing even after applying pressure, is seen in lymphatic obstruction or in case of mixed edema. So you observe no indentation on pressure in case of non-pitting edema. But in pitting edema, which we call as generalized edema or anasarca, it's widespread, it's severe, and it involves the subcutaneous tissues and serous cavities. Okay, so this gradation of edema is +2. What does it mean? Edema can be graded as 1 plus or 4 plus, depending upon the depth and duration of the indentation. 1 plus when it is mild, 2 mm, say less than 2 mm and disappears faster. 2 plus when it is moderate, less than 4 mm, lasts for 10 to 15 seconds. 3 plus when it is severe, 6 mm, lasts for more than 1 minute, and 4 plus very severe when it is about 8 mm and lasts for 2 to 5 minutes. So this is how we do the grading of edema. So in this patient, the pitting edema is seen. So you can say it is pitting. It is because it is involving the subcutaneous tissues and serous cavities, mainly the dependent parts. And it is plus 2 grade means it is moderate. About 4 millimeter indentation is there, which is lasting for 10 to 15 seconds after the application of pressure is removed. Now, this was about the pitting edema, the general finding. Now, what about the JVP of the patient? The jugular venous pressure of the patient is 4 centimeter. I would like to throw the light that JVP is a non-invasive marker of the right atrial pressure. Right atrial pressure, or you can say the central venous pressure. It is an indirect measurement. It helps in diagnosing the right-sided heart disease, the pericardial diseases, and the volume status of the patient. Now, JVP reflects the right atrial pressure, and it is normally 3 to 4 centimeters above the sternal angle. Okay, and we add a plus 5, it becomes 8 to 9 centimeters of water above the right atrium. Okay, and this JVP is observed in internal jugular vein, just medial to sternocleidomastoid. And you can see that the patient is reclined 30 to 45 degree, the neck muscles are relaxed, and the patient is asked to turn left. And then the vertical height between the sternal angle and top of the venous pulsation of the internal jugular vein is noted. So this was a background about JVP. Now in this patient, it is 4 centimeter. As we know, 3 to 4 centimeter above the sternal angle is the normal value of the JVP. Now this JVP is 4 centimeter, which means it is also towards the higher side. So the patient is showing a right atrial pressure increased because the JVP is raised. Okay, the pitting edema, which shows that there is collection of the subcutaneous tissues and fluids in the dependent parts. And the BP is also has towards higher side. The pulse is also towards higher side. So these are all indicating towards the cardiovascular disorder. So by looking at the history, we were coming to the inference that it is a respiratory pathology, but by the general physical examination, we come to the inference that it is related to elevated left ventricular pressure as well as right atrial pressure. On right atrial pressure, it will also because of the right ventricular pressure. So you can just come to the conclusion that it is a biventricular pressure is raised. Okay, and pressure is raised, so it will result into the biventricular hypertrophy. Okay, so this is what we can pay inference only by the general physical examination without the need of any of the investigations. Now the systemic examination, the abdomen, the per abdo examination, it is showing hepatomegaly, okay, the enlargement of the liver. Now you might be thinking why hepatomegaly is occurring. Then respiratory system, what you get in respiratory system? Bilateral dull percussion notes on the costophrenic angles. So what is costophrenic angle? I'll just discuss the X-ray of the patient and I'll tell you. Now auscultation reveals basal crepitations in both the lungs. So these are the systemic examination. We are doing a per abdo, it is showing hepatomegaly. We are doing the respiratory examination. It is showing bilateral dark percussion note on costophrenic angle, and auscultation is revealing the basal crepitation in both the lungs. Now, for cardiovascular system assessment, we ordered a PA view, X-ray chest. It is showing cardiomegaly. So that was we just inferred from the general examination also that there is enlargement of both right and left ventricle. So there will be a cardiomegaly, which is very obvious. And ECG showing the signs of right and left ventricular hypertrophy. Again, we have done the ECG of the patient. I will just show you the pictures. And 2D echocardiography showing the dilatation of all the cardiac chambers, okay, with poor contractility of the cardiac walls and the reduced ejection fraction. These are the three findings which we are getting from 2D echocardiography, which we could have easily assessed either through the general examination also, but we have, for confirmatory diagnosis, we have ordered these investigations. So again, the provisional diagnosis of this patient comes out to be congestive cardiac failure, or you can say the biventricular failure, the failure of both right and left ventricles. So this is the PA view of the chest. This is showing cardiomegaly. As you can see, this is the ECG of the patient. The tall QRS complexes obviously seen in case of right and left ventricular hypertrophy. Okay, and then the 2D radiography, the dilatation of the four cardiac chambers, the very weak cardiac walls, and obviously the contractility is reduced and there is low ejection fraction. Now, what about the clinical queries? Clinical queries which are coming in mind is what is the cause of shortness of breath in this patient? Okay, what is the cause of increased pulse rate in this patient? What is the cause of raised JVP and liver enlargement in this patient? What is the cause of dull percussion note in the chest? What is the cause of basal crepitations in the chest? And what is your probable diagnosis based on physical and lab findings? And how can you manage the patient keeping in view the pathophysiology of this condition? These are the clinical queries. Now let's just solve these clinical queries one by one. First, the cardiac failure or biventricular failure is what? It is defined as the failure of the heart to pump enough blood to meet the demands of the body. Right? The heart is not capable of providing the blood which is required by the body. And what could be the causes? Causes could be the intrinsic pump failure in the heart itself. There is some problem which can be attributed to the weakening of the ventricular muscle. Now, increased workload on the heart, okay, which is resulting in increased afterload and preload. Now, restricted filling of the cardiac chambers like cardiac tamponade and constrictive pericarditis. So, in these conditions, there may be cardiac failure may occur. These could be the three causes. Among the three causes, one could be the reason for the cardiac failure. Now, cardiac failure, the pathophysiology of congestive cardiac failure. Congestive cardiac failure means which shows the signs of both left ventricular as well as right ventricular failure. So depending upon the ventricular involvement, we have single ventricular failure like LHF, the inability of the left ventricle, RHF, which we also call as cor pulmonale. It is the inability of the right ventricle to pump the blood into the pulmonary artery, right? So, and biventricular failure is congestive cardiac failure, CCF, the signs of both, in which the signs of both LVF and RVF are present. So, let's see what happens in case of left heart failure. Left heart failure means simply the left ventricle is not able to pump the blood. So there will be decreased stroke volume. Stroke volume is the amount of blood which is ejected during each cardiac cycle. So this decreased stroke volume will be there. So because of stroke volume will be increased, so the end diastolic volume will increase. End diastolic volume will increase, then therefore the end systolic volume will also increase. And there will be raised left ventricular pressure because of increase in both the volumes. And therefore there will be a raised left atrial pressure, and there will be increase in pressure in the pulmonary arteries as well. So what will happen? The pulmonary edema will happen because the pressure is increasing. So because of Starling's law, this increased hydrostatic pressure will push the fluid into the interstitial fluid. So what will happen that the pulmonary edema is leading to difficulty in breathing. Okay, so pulmonary edema will develop, which will lead to difficulty in breathing. And because pulmonary edema is there, some sort of pleural effusion will be there. So basal crepitations and obliterations of the costophrenic angle will also be observed. So this is one of the cause of the auscultatory findings, and there's those of the obliteration of the costophrenic angle, one of the observation we have seen in the PAV of the chest. Now, one thing should be kept in mind that a long-standing right ventricular failure also leads to left ventricular failure. So primarily this left ventricular failure may not be the intrinsic one. It may be the consequence of a right ventricular failure. Now we come to the right ventricular failure. So raised right ventricular failure will cause the increased right atrial pressure. This will increase the JVP, the jugular venous pressure, and increase in pressure will increase the IVC, inferior vena cava pressure. And what will happen because the IVC is pressure is increased, there will be congestive hepatomegaly. And because of this raised pressure in IVC, there will be edema development in the dependent parts of the body. So these are the consequences of right heart failure. Now we come to the most important part, that is the physiology of the management. If such patient comes to you and you see this type of diagnosis and you see this type of investigations and it comply with this, what is going to be the physiology of management? First, you have to perform the BLS, the basic life support. Okay, you have to do the airway maintenance, and you have to provide oxygen to the patient, oxygen therapy to increase the amount of dissolved oxygen, resulting in improved tissue oxygenation, right? Because there is oxygen demand is increasing and it is not supplied properly. So therefore, oxygen therapy is vital. Now, complete diet to advise emotional rest. And as far as diet is concerned, the salt and fluid restriction to reduce the volume overload in the body. Already the ESV and EDV are more, so we would like to just limit the salt and fluid in the diet of the patient so as to reduce the volume overload in the body. Now, what are the drugs? The rationale of the drugs in the management of CCF. First is the digitalis. Digitalis is going to increase the myocardial contractility. As we know, it has an action on sodium ATPase pump. and it is increasing the myocardial contractility by increasing the availability of calcium. And what about optimizing the preload and afterload of the heart? Preload of the heart can be optimized by using diuretics, venodilators. Diuretics, they are going to reduce the fluid volume. They are going to cause diuresis. So that's how they are just going to come they bring the fluid down, fluid overload down. And venodilators, we would like to dilate the veins so that the pressure could be reduced. And then we come to the role of most important thing in medicine, that is the ACE inhibitors and ARBs. Now, what are ACE inhibitors and what are ARBs? They require both for optimizing the preload as well as for decreasing the afterload. We are using the venodilators and arterial dilators, that is fine. We are just want to reduce the pressure in these arteries and veins. But why we are using ACE inhibitors and ARBs? They are most vital for the drug management. I would like to tell you about ACE inhibitors. ACE inhibitors includes drugs like enalapril, ramipril, and lisinopril. What they do, they inhibit, as the name suggests, they inhibit angiotensin converting enzyme. They decreases the conversion of angiotensin 1 to angiotensin 2, and consequently they decrease the aldosterone level and they reduce the vasoconstriction phenomenon, but they increase bradykinin, since ACE also degrades bradykinin. Now, what are ARBs? ARBs are nothing but the angiotensin receptor blockers. What included in ARBs? Losartan, valsartan, and telmisartan. They block angiotensin 2 type 1 receptors, or you can say AT1 receptors, which prevents the action of angiotensin 2. Again, angiotensin 2 is causing vasoconstriction and aldosterone release. So by blocking these receptors, again, what you are doing with the ACE inhibitors, you were decreasing the aldosterone level and you were decreasing the vasoconstriction. These were the actions of angiotensin 2. So you are preventing both the things. But these ARBs are not affecting the bradykinin metabolism. Okay, they are not affecting the bradykinin metabolism. What is the effect? Effect of both is that they are reducing the afterload and preload of the heart. They will reduce the workload on the heart, they will reduce the blood pressure, and they are also important for the slow progression of the chronic kidney disease and heart failure. ACE inhibitors additionally causes the vasodilator effect due to bradykinin accumulation. Now, clinical uses, they are used in hypertension, they are used in heart failure with reduced ejection fraction, as we have seen, and they are used post MI also to prevent remodeling, and in case of diabetic nephropathy or CKD with proteinuria. Now, what are the clinical uses we have discussed? Now, side effects, ACE inhibitors will produce dry cough, okay, because of increase in level of the bradykinin. They'll cause angioedema and hyperkalemia and hypotension, and contraindicated in pregnancy and bilateral renal artery stenosis. But ARVs के case में no cough, no bradykinin related angioedema, and hyperkalemia would be seen as a side effect of ARVs. So you have to go for the management of hyperkalemia as well. So what are the key differences between ACE inhibitors and ARBs? Let's quickly summarize this. ACE inhibitors में जो enzymes or receptors on which it is working is what is ACE inhibitor is blocking ACE, angiotensin converting enzyme. Bradykinin is accumulating, so there will be cough and angioedema. And cough, angioedema, and hyperkalemia are the side effects. And the first line drugs in hypertension and heart failure. And ARBs are blocking the AT1 receptor, so no effect, no cough. Hyperkalemia and hypotension and no cough are the side effects. Alternatively, the ACE inhibitor is not tolerated. Obviously, you have to go for ARBs. Now, since I've used the term angioedema, I'll just like to summarize angioedema. Angioedema is sudden, localized, non-pitting edema of the deeper layers of the skin, mucosa, and subcutaneous tissues. And it is involving the face, lips, tongues, larynx, and GI tract. Now, due to increased vascular permeability, particularly caused by histamine or bradykinin, angioedema occurs, and this is classically seen in case of acquired angioedema, and it is seen in hereditary angioedema also, and it is basically because of bradykinin. So, if you want to treat it, you have to use bradykinin antagonist. Okay. Now, what were the complications of angioedema? Is in the airway obstruction, which is life-threatening, and severe recurrent attacks in hereditary forms. So, angioedema you have to avoid, and it is mostly the side effect of ACE inhibitor. So, most important drugs for this management is going to be ARVs. So, this was all about this case, and thank you so much for listening. Thank you.